Hi, good afternoon, and welcome to the Hartford Medical Society's Lunchtime Learning Webinar. I'm Tessa O'Sullivan, the Executive Director of the Hartford Medical Society, and I'm thrilled to have you here today. Just to let you know a little bit about us, most of you probably have heard, the Hartford Medical Society was founded in 1846. And it was founded to have doctors who joined together to share resources, which kind of created the basis of our historic library, currently located in the basement of the Yukon Medical Center, but it's moving and moving soon to the Watkinson Library on Trinity's campus. So we're coming back to Hartford, and that's very exciting. Now, what doctors wanted in 1846 is actually what medical professionals want today. They wanted to learn from one another, to promote collegiality, and to remember the lessons of the past that can come and help shape and inform the challenges that we face today. Now, a quick item of housekeeping is that we welcome questions, and I know you'll have them. So please use chat, type in your questions, and at the end, we will ask questions, and we will also be able to have you come and join us. Is anyone else having trouble with sound? I saw a message from Dr. Spar. If you can hear me, just somebody type in. Sound is fine. Okay, Dr. Spar, it might be, we can try to troubleshoot that offline. But I'd like to welcome our presenter today. Oh, great. So Dr. Spar's back with us. Today, our presenter is Dr. David Crombie. Dr. Crombie was educated at Dartmouth College and received his doctorate or his MD from Tufts University School of Medicine. He trained in surgery at Harford Hospital, and he served in the U.S. Navy aboard the carrier USS Hancock during the Vietnam War, as well as service at the Naval Hospital in Newport, Rhode Island. He had a career in general surgery at Harford Hospital from 1969 to 2004, mostly as a private practitioner, minus the 10-year span, which he was full-time at the Department of Surgery. His leadership positions during this time include chair of the Hartford Hospital Medical Ethics Committee, director of the Department of Surgery, president of the Hartford Medical Society, thank you for your service to us, president of the New England Surgical Society, and the editor of Connecticut Medicine, the Journal of the Connecticut State Medical Society. That was from 1999 to 2011. And without then further ado, I would like to welcome Dr. Crombie.
Thank you, Tessa, and good afternoon to you and to all of those who have tuned in to this discussion that I hope will be worthwhile and productive of some comments from people online with us. The title is a referral to the philosopher and writer Joseph Campbell, who, to quote him directly, "Follow your bliss, and doors will appear where there were previously only walls." And so his advice to all of us as a philosopher was, as you select your career or your life's mission, follow that which brings you joy, follow that which brings you excitement, not what someone else tells you is exciting. And so while the Joseph Campbell reference is primarily based upon his guidance to all of us about the selection of a career, it's my belief from my own experience in medicine that the same advice could be applied to guide us to choose, quote, an avocation, meaning something that might be a hobby or a parallel area of interest that is exciting intellectually and exciting to us, but that we are not earning our living at. And my thought is, from my observation and my own life experience in medicine, my thought is that that particular avocation is a built-in, or becomes a built-in defense mechanism, if you will, to buffer the stresses and strains that may result from a medical career. But I think that the same could apply to people in other walks of life whose work brings strains that can be demoralizing. And in particular, in our present time, um, with the dangers of burnout occurring both in medicine and in other disciplines or in other careers, any way that an individual who is under a fair amount of pressure to work and do things that are challenging each day, to have a means of defending against the onslaught of burnout, may indeed be worthwhile for us in medicine. And this diversion, if you will, in our avocations, um, is, call it, an antidote against the troubles that might arise with burnout. Now, burnout can be summarized in sort of three parts. Part one is the individual demonstrates exhaustion with his or her job. There is a degree of depersonalization. In other words, and in medicine, that is certainly a concern, because as we depersonalize the job of being a doctor, we really take away much of the sense of mission and much of what our patient population, or our patient people, um, find to be important in their context with the doctor. And the final thing is, or the third thing, is a diminished sense of personal accomplishment. Those are the elements of burnout. Now, in the recent past, within the past 10 years or so, the American College of Surgeons screened or surveyed its membership and asked, how many of you surgeons, members of the American College, have can look back and say that you have had episodes or periods of time in which you were suffering burnout? And the answer is 40%. So for the profession of medicine, anything that can blunt or buffer the dangers of, or the effects of, burnout uh, should certainly be refined in some way to apply as defense against the dangers of burnout. And I would say that looking back on my own career, those my interest in history, and the history of medicine, and local history, which has sort of nurtured an evolution into some of the other medical humanities, including art and ethics and so on. Those, in my personal experience, have been helpful in making the effects of burnout be somewhat diminished. And when you look at the training of some of us in my generation, we were trained by individuals who overworked themselves. And their overwork was the guidance to their students, namely us. Never say you're tired. Never say you can't take on another duty. Don't just accept responsibility, invite responsibility. And certainly in the days of 50 years ago, we were not saying, oh, gee, I got to do everything I can to preserve a work-life balance. So we are a generation of folks who have worked our way through an evolving medical profession in which the electronic medical record arrived and the computerized office system that required all of our doctors to take their laptops into the treatment room and be recording things. And so the adjustments in our generation, not to deny the adjustments in work hours that we saw happen in the early 90s, so that house officers were prevented from working 120-hour weeks. So in our generation, the generation that I represent, this evolution to a danger of burnout has been fairly significant, I would submit. So back to the idea of an avocation, this is some of the folks that are tuned into this webinar are friends of mine who have demonstrated in their own performance the value of avocation. I think of Ira Spar, who has been a very active member of the Society of Civil War Surgeons, has written a number of books derived from his knowledge and pursuit of that particular area of interest, while still doing his work in orthopedics and hand surgery. And I would say has demonstrated an ability to keep on an even keel professionally, while his avocation kept him interested and excited about the work he was doing. And certainly our president, Bern Costo, the same way. The artifacts and books relating to his specialty of urology have become such a area of interest and knowledge that he is relied upon by the medical library of his alma mater at Yale to be their consultant on that matter. And Bill McDonald, I'm not sure whether Bill is tuned in, but Bill is the leading expert on Horace Wells, who is a Hartford dentist that started general anesthesia. Say what you will. So these are individuals that have practiced their profession while being very actively engaged in I would say, an avocation. Now, if you want to hear about the what I would call the poster child of balance between a vocation and an avocation, I would submit the case of Theodore Roth. Theodore Roth was a German surgeon born in the early 19th century, 1829. And we think of him as the originator of the gastrectomy. And he also, although it isn't advertised very much in the history books, but he was also one of the first to ever do a laryngectomy. Well, anyway, Theodore Roth became the leading surgeon of Europe in the late 19th century. And he, to go back into his childhood, he had a very strong musical beginning. And when he was a college age student, he said to his mother, who was a widow by then, you know, I think I would like to be a concert pianist. And she said, well, Theodore, there's a lot of scientific advances being made here. This would have been mid 19th century, 1848 or so. Lots of scientific advances. You could attach your wagon to the star of science, and with your understanding of and desire for music, you could have music as a, she said, hobby. And so, in deference to his mother, he went to medical school in Berlin and was an outstanding student, worked under some of the giants of European surgery in the late or middle 19th century, and became a sought after surgical leader in Europe. His first job as a faculty member was in Zurich, Switzerland. And who should he meet in Zurich but Johannes Brahms? Now, Johannes Brahms was a relatively, other than his musical genius and his musical training, he was a relatively uneducated man, whereas Bill Roth was very cosmopolitan, had a full college education plus medical school, had language and writing skills. He had many things that poor Brahms, poor in only that regard, did not possess. So here was Bill Roth, cosmopolitan European educated man. Here was Brahms, the musical genius, and Bill Roth, with his interest in music, formed the two of them formed the friendship based upon the musical venue. So Brahms, of course, when he realized that Bill Roth was such a learned musically, would give his written pieces to Bill Roth to look at. What do you think of this quintet? What do you think of this piano sonata and all that sort of thing? And Bill Roth would offer an opinion and advice. And so here was Bill Roth now with a very strong musical ingredient in his surgical career. He is the originator of the surgical training program that is still standard both in Europe and in America. And he established a program in which individuals were offered the opportunity to join his department for a period from 4 to 8 years, during which they would engage in advanced, or shall I say, graduated responsibility in both operative surgery and in the care of patients outside of the operating room. And so Bill Roth, with his musical avocation, each resident who applied for his program was asked, what instrument do you play? What do you do musically? And so we realize now that his residents were evolving in the same way as their professor had evolved. And one example of that would be Mikulicz. We use the term Mikulicz, for example, a lap pad. He was in abdominal surgery. We have an oversized sponge called a lap pad. Well, it was originated as, quote, a Mikulicz or a Mick pad, M-I-K, to represent the individual who developed it in surgery. And so here would be Bill Roth in Vienna, his next site of surgical professorship. And the weekend would come and he would take some of his musically gifted residents and go off to Bavaria, where he had a vacation spot, and they would play chamber music and so on and enjoy themselves. So I think of Bill Roth as having evolved two absolutely beautiful areas of genius. One, his surgical innovations, and two, his ability to maintain his musical interests. So I think that is a good example. And I have a friend, not to elaborate too much, but I have a friend who is an Episcopal priest, and he was in charge of a parish in a congregation in the Hartford area. And he, as a hobby, had woodworking as his hobby, and I have seen slides that show his woodworking shop, and it is not anything but an expert at work when you see the style of his workshop. Well, anyway, in recent years, he was hiking with a family and had a fall. And his fall resulted in both a head injury and skeletal injury, which ultimately caused him such a disability that he had to retire from the ministry. And what saved him? What saved him was his hobby of working in wood was encouraged by his family and friends to a greater degree than had ever been seen in his case before. And even today, when he talks about it, he talks about his woodworking with a degree of reverence that demonstrates to me, at least, that his life and career were saved, or at least his interest in life was saved when he had to retire from his ministry. So I think that avocations may have some fairly strong contributions to the life of our um, doctors. Now, in my own case, with an interest in medical history, I had the opportunity to take on the editorship of the Hartford Hospital Bulletin back in the late 1970s. And in 1979, Hartford Hospital, where I had been training but was now in practice, Hartford Hospital celebrated 125 years in existence. Well, there were those in the leadership who felt, gee, I ought to make a bit of a celebration about this. And since I was in charge of the bulletin, I thought we'll do a memorial issue of the bulletin. Well, Abe, we got graphic help. We did some special things to make the 125th anniversary issue of the Hartford Hospital Bulletin a worthwhile contribution to the possessions of those on the medical staff and the employees. In my own case, I wrote a history of the Department of Surgery going back to the first surgeon in 1860 and up through our colleagues, Jack Reed and Jim Foster and Dr. Standish, and others whose names would be familiar to some that are attending this webinar, came forward and said, oh, I'd like to write about the urologists, and I'd like to write. So all in all, we had a very worthwhile memorial booklet, which is still called upon for tidbits of history about Hartford Hospital. And lo and behold, after that was done, 25 years went by, the hospital got to 150th anniversary. And now many of those who had been involved in the previous were engaged in writing a book about the 150th anniversary of the hospital, which I was involved in. So here again, my interest in history, my interest in writing resulted in some contributions to the I'm going to say, intellectual and memorial world of our community that I felt very proud of. The other point I'll make is it tended to spawn interest in other things that were not originally strong in my arena, if you will. For example, in the 90s, 80s and 90s, the JAMA, Journal of the American Medical Association, was a weekly publication, and there was a cover editor, doctor by the name of Dr. Teresa Southgate. And Dr. Southgate took the table of contents cover, which was traditional on JAMA up until then, and decided she would seek out works of art and sculpture and so on, photography, that could replace this somewhat scientific cover with a pictorial cover. And she or someone else would write a commentary about the work of art. Well, this became such a fascination of mine that some of my friends were pointing the finger at me because I was saving the covers and the commentary and throwing away the medical articles. And so this was an example of the avocation somehow even taking precedence over the vocation. But much of the printed material in JAMA, as anyone knows that's listening to this, is medical, not surgical. So anyway, that was an opportunity to expand into the world of art and relate it to medicine. And then in the early 80s, the living and dying issues of medicine and the ability to resuscitate and so on, intensive care units, it became apparent that we needed ethical guidance. We as doctors needed ethical guidance. And so a team was put together, and I was asked to sit on the ethics committee of Hartford Hospital, medical ethics, mostly end-of-life decision-making. And that particular opportunity was just wonderful because here was a group of perhaps 18 to 20 people, including some doctors, but in addition, nurses and chaplains and social workers, and there was psychiatry input. So a multidisciplinary team of people involved in the care of patients and who had an interest in the death and dying, if you will, but also ethical aspects of medical care, getting together and discussing cases and serving in a consultative role for the hospital. And as a matter of fact, not only for the our hospital, but also serving as a medical consultation team for nursing homes and other smaller hospitals that didn't have a committee. So I did serve on the ethics committee, and later on, when the ethics the chairperson retired, I served as chair of the ethics committee for 3 years. And my interests have always been to my interest in history of medicine has caused me, when new applications appeared on the horizon, I would use as an example, stapling devices. When stapling devices became commonplace in general surgery and abdominal surgery, it was worthwhile to go back into the early 20th century and see some of the primitive designs for stapling that were produced both in Europe and in the United States, and put together a package in my mind and for residents in training of how it is that these stapling devices that seem so slick were originated, if you will. And the same would be said about the laparoscope. I mean, laparoscopic techniques evolved for general surgery, evolved in the early 1990s, and yet that was not really a new concept to the gynecologists who'd been doing laparoscopic work for a long time. And so, and out of that arose arthroscopic and thoracoscopic and other parts of the human body that were explored through the use of these scopes. So I would submit that it is the original interest in the history and literary elements of medicine that has given rise to more than was the size of the original package, and all of it became part of an avocation while I was involved in taking care of patients as a surgeon. I think that there is a human dimension that is fostered by the non-scientific aspects of medicine, and that element has been important to me because I think that in the age of rapidly advancing technology, the ability to be a real doctor at the bedside is still the most important element. The technology is valuable, but a doctor is still a doctor. And we go back really to the 1890s with Osler. And Osler at the Johns Hopkins would have, in his daily rounds, would have a great entourage of trainees, mostly medical, non-surgical. He would go into a room to interview a patient. He would get a chair, pull it up next to the bed so that his face was at the same level as the patient lying in bed. And he would have a comforting dialogue with the patient. And that was a means of learning about the patient's trouble through the Osler method that was adopted by medicine in all the various disciplines. And certainly those of us that worked at Hartford Hospital and knew some of our mentors well and observed them in their human dimension recall how important it was for all of us to sort of pick up the hints that they transmitted to us that were valuable means of gaining the trust of the patient. I think, for example, of Dr. Standish, who in my early years as a resident was the chief of surgery at Hartford Hospital. And he had a very busy practice and was president of the medical staff, chief of surgery, a lot of responsibilities and a lot to crowd into one day. And he had two residents assigned to his service, and my partner and I would meet him in the morning in the cafeteria at the hospital at 6:30. We would have breakfast together, and by 6:45, we would be up on the 12th or 11th floor to see the first patients and work our way down to the operating room. And Dr. Standish wore shoes. He had a pair of Wellingtons that he wore quite often, and they had a pretty hard heel so that when he walked on the tile floor, you could hear his heel hit the floor. And it was pretty tough to keep up with him sometimes because he had a lot to do before the operating room. So he would have a click, 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 click going down the hall. But within 10 steps of the patient's room, he would pause. He would slow his pace. He would walk into the room so that that patient in the room would think that the only patient he was seeing that morning was that woman lying in bed. So that was a means of conveying to us that the patient is so important, and the human dimension of medicine, which for me arose out of a kind of a historical literary interest, is still paramount to me, and is an area that perhaps led to my being asked to serve on the ethics committee. So I would go back to my original premise, which is Joseph Campbell was guiding people in their selection of a career or in the selection of a life's mission. And he didn't confine it to the money-making mission, but also to any pursuit that if it brings you joy, pursue it, and it will open doors, as he said, and it will open doors to other areas that are related, and don't ignore it. And in medicine, I would say, in an age of rapidly changing technology and dangers of burnout, that parallel life or avocation often included in the broader banner of medicine is a defense against setbacks and burnout in particular. So with that, Tessa, I should pause and maybe listen to some questions or discussion and see, and I could continue if we need.
Yes, so we would welcome if you have a comment to please type it in or raise your hand, and we'll welcome you to the inside of the Zoom webinar. But my question is, where did you get your interest in history?
Well, I here's what I think about my interest in history. My father was a man that never got to high school, and he was pretty high in the business world just by virtue of being an intelligent guy who worked hard. And he was very much attached to the history and background of things that were happening in the current time. And he read magazines, and he stayed current on matters in the business world, and always was looking back on, what preceded this. And so that I got that as kind of a childhood message from him, that the history of things was important and could maintain, it gave continuity to whatever was happening in today's world.
Thank you. And what is your favorite story in history that looking back, what do you think is one of the more important stories you were able to share while working?
Well, there's a lot. One that I think of is Harvey Cushing, that everybody knows by name. Harvey Cushing was one of the most prominent surgeons of American history in medicine. And Harvey Cushing went to work at Johns Hopkins in the middle 1890s after graduating from medical school at Harvard, and wished to train under Dr. Halsted, who had established a surgical residency program there. And there were two leading surgeons, Halsted, who was the professor, and John M.T. Finney, who was a practitioner surgeon as opposed to a pure academic surgeon. And so, and John M.T. Finney, it should be said, became the first president of the American College of Surgeons when it was formed in 1913. So anyway, here's Harvey Cushing, a young graduate from Harvard Medical School, who is now in training in Halsted's program, and he came down with appendicitis. And so Harvey Cushing had to decide, there's two leading surgeons at Johns Hopkins. Do I want the professor, who's kind of an academic, or do I want the practitioner surgeon who's a little more practical? And he chose John M.T. Finney to be his doctor. And I think that is a great story, because there is a bias that is still present in medicine and in surgery, that the academic individual is important to learn the facts and learn the science, but nothing beats the practical experience. And so Harvey Cushing, at least in his own choices, demonstrated that.
I think I would make that choice too, if given that opportunity. I'd rather have the practitioner than the person who's more theoretical.
Right.
If they're going to have their hands inside me.
Right.
Oh, and we got Dr. Spars coming to join us.
Can you hear me?
Yes, we can.
I can hear you.
Dave Crombie, to me, has always been the adult in the room. And I think his remarks this past hour should be required viewing by medical students. And it's one of the things why I urged we get medical students at our meetings where they can hear and learn things you're not going to learn in books. When I was president of the Harford Medical Society, I had a session of 4 doctors who wrote books present their piece, 15 minutes each. One was an oncologist from Bristol. The second was an ER doctor from New Britain who wrote a murder mystery where the chief of cardiologists was the murderer, and he was then executed. In real life, Dr. Mucci hated the chief of medicine, of cardiology. So it was kind of a subliminal thing. The third was a classmate of mine, Al Lowhouse, in medical school, and he wrote a book about his medical misadventures where he was operated on, it didn't go well. And the fourth was Dr. James Foster, who wrote a terrific book on Shakespeare and medicine. he was deceased. He had died just a few months before the meeting. And I had a professor from CCSU in English discuss the book. And it just struck me how wonderful the talent that exists in doctors that usually you don't hear about till they're dead. And Dave can remember the session we had with the doctor who was born in Germany. His father was killed in the Battle of Stalingrad, and our own pediatric cardiologist both wrote books about their history. One was a Polish Jew, the other was, his father was in the Wehrmacht, and they both presented their books, and I thought it was the best meeting we ever had, as tears flowed. At any rate, and one last thing, the replacement for Dave Crombie at the Connecticut Medical Journal was an oral surgeon who rotated through Harford Hospital with me. And he always had a kind word to say about my books, but the best thing ever was he wrote a piece about doctors who wrote books, and in it, or who were writers. And he quoted the famous Russian playwright, and he quoted John Steinbeck, who won the Nobel Prize. And then he mentioned me. And I was just, it was one of the best days of my whole life. So Dave, thanks so much for your remarks. And I think this should be preserved for the medical classes as well.
Thank you.
I'm
Thank you
glad
for
we're
your
recording
remark.
it.
Yeah.
Dr. Herzog?
David, can you hear me?
Yes, we
Yes.
can.
David, how would you distinguish a hobby from an avocation, or does it make a difference?
Well, I went to Merriam-Webster for it, and I have always felt that an avocation signified an intellectual investment, and a hobby was work with your hands and relax. But when you look it up in the dictionary, they're synonyms. So my bias is think of an avocation as something that takes an intellectual investment, and think of a hobby as, I mean, I think of Bill McCauley, who's died this past year. Bill McCauley had as a general surgeon, he devoted every single Wednesday morning to a tennis game. Mm-hmm. And it sustained him. It helped him. I wouldn't minimize it, but it was his hobby.
Yeah.
And whereas I think that some of the things that are intellectually challenging that people pick up can be thought of in better terms as avocations, but that's a Dave Crombie.
I like your interpretation. I like it.
We had Dr. Salner saying this was a great talk, so congratulations. But as physicians, we have devoted so much time to our practice as well as dedication to mentoring. How well have med schools and hospitals and practices done in facilitating the highly expert and experienced end of career practitioner done in finding mentoring roles, quality roles, et cetera?
Yeah, I think, I don't know, there might be others in the group that would respond to this, but my own view is the academic side gets on a time clock to cover material and get almost to the point where they have to report to their chief as to what they have covered, and the human dimension gets shortchanged as if it was of minor importance. But doctoring is all human dimension, my view. And so it's been criticized, for example, when ethics committees were first formed, the word around the medical communities was, well, gee, look at these doctors. They graduated from medical school and they never had any ethics training. But they learned an awful lot about sodium. And so I think that has been a criticism, and it's perhaps a justifiable criticism. And some in the group may know that when I left the Department of Surgery back in the 90s, I was asked by the hospital, we'd like to do something to commemorate your tour here and so on. And so they established an annual lectureship and asked me what the title should be. And I said, the title should be the humanities in surgery. And the humanities in surgery are what I've been talking about here, mainly the literary, the historical, the ethical, the spiritual. We haven't gotten into that, but and lo and behold, 23 years have gone by now, and they've had a person from around the country, California to New England, give the talk each year, and they have been remarkably good. So I think they're and remarkably well attended, and acceptance by those who have been approached to do them has been very positive. So it appears to me that the people that hear the message and the people that deliver it are very interested in doing so, about the human dimension.
We have Dr. Grave ready to speak.
I just want, Dave, can you hear me?
Yes, you're a little loud though.
Turn myself down. I'm sorry, because it's orientation week. We have an outside speaker for our grand round, so it's a. But I wanted to pop on and just tell you it was great to see your name crop up. I forwarded it around to everybody here at St. Francis. I hope a few people joined in, and it's just good to see you.
Thank you.
Well, and we'll also have a recording of this, so I'll send you the recording for you to
Would
share
you?
with your colleagues.
I really appreciate that, because I've got to run. I'm down in clinic again at 1. I got to head off to that, but I'm sorry I missed the talk, but I look forward to listening to it.
Great. Thank you.
It's probably more important to be working orientation and getting these new doctors in and encouraging them to find something in the humanities.
Right.
Sure about that. I try to read it in just like David always did. All right. Thank you so much for coordinating it. I appreciate it.
Thank you
Bye-bye.
for joining us.
Bye-bye.
I believe that's all the hand raising that I see. So if anyone else wants to come on, oh, Dr. Spars wants back in, he can do that. And unmute Dr. Spar. There you go.
I have a question. The question is this: if you went into the hospital cafeteria where the doctors sat around tables in the 1950s, the 70s, the 90s, the 2020s, and you asked how many of you are happy, do you think there would be any difference in the response in the decades that have preceded us? Or do you think that this modern generation is any different than we were?
Well, my thought on that, Ira, is that there is a somewhat subliminal, at times even seething, discontent among doctors. And when I entered the medical world by starting medical school in 1957. And so what I saw then among the folks that were on the faculty, and then went across the street, this was at Tufts, and saw those that were doing operations and running endocrine clinics and so on, went to grand rounds during those 50s. I was seeing people that were excited and interested and did not seem discontented. When I talk to my colleagues now, I don't see them in grand round settings so much, but when I talk to my colleagues now, there is an element of discontent, even disenchantment with the milieu in which they work, and I think it is negative. And I think it transmits to the patients. And when I go as a patient now, as an old guy, I see a little bit of a detachment almost among the doctors. In other words, in defense of my own emotions, I'm not going to get up close and chummy with you, kind of. And the up close and chummy, which everybody talks about, warm and fuzzy, they have all sorts of negative adjectives about what it amounts to. But that was, to me, what the trust was based upon, was the feeling that this other human being with an MD degree is interested in me like nobody else in the world. And now the detachment makes me think gee, I got other agendas, Dave. I'm not going to be able to spend more than 10 or 15 minutes with you and so on. So I see disenchantment to some degree. Are they throwing their glove down and refusing to play right field? No, I don't think it gets to that point. But there are people retiring early who are still very much in possession of their capabilities. I don't mean so much in surgery, but in those places where the technical aspects are not as important, but the intellectual aspects are, people retiring early just because the setting is uncomfortable for them.
That sounds about right. Dr. Spar?
Um,
Oh, there you.
Do you agree?
I always value Dave's remarks. I'm not sure that the average physician has changed all that much from when I started practice. I remember doctors complaining when I started practicing in the 1970s, just as much as they complain now. I don't really have that contact with the younger guys much. I have the same feeling as you. I go see doctors a lot now also, and you mostly look at the back of their heads and a computer screen. But it's just still an individual thing.
Yes,
And there are good ones and there are some that aren't so hot.
yes, I would agree with that.
You know, there was a TV show called Marcus Welby, and
Yeah.
everybody said, oh, we wish, why doesn't all our doctors behave like Marcus Welby? Well, the truth was the actor who played Marcus Welby was a fall down drunk who beat up his daughter and his wife in real life.
Yeah, I wouldn't want that to be my experience.
Right. Yeah, it is individual. I'll agree with that. But when you see an individual who is disenchanted, it really, you talk about getting a rotten apple into the barrel. It does affect the image that you have of the others.
Well, and I've been impressed with learning more about people in the medical field who have avocations that they are truly passionate about, whether it is artistic, musical, historical. You find that in other industries as well.
Yeah.
But it's been fascinating that the number of artistically inclined physicians and medical professionals seems to be a larger number than in the general community. At least I think anecdotally, but I don't have any stats. I think it'd be interesting to find that out.
Yeah, I kind of agree with that, Tessa, in the sense that, in our journals of the past, um, the New England Journal, as an example, stuck pretty much to science, now has a lot to do with the social sciences. I do not recall any journals of the 1950s and 60s with a poetry column or a photography column. And when I was in charge of Connecticut medicine, we found that our readership was very much grateful for the appearance of artistic and photographic and poetic and literary additions from our readers being submitted to the journal for interest. So I think that may have increased in the past 50 years, that element.
Well, we are on our last moments, so unless anyone has a further comment, I first want to thank Dr. Crombie for sharing this talk with us and allowing us to record it so that way we can share it with other people. I am thrilled to be working with such an amazing group of medical professionals at the Hartford Medical Society. Visit us on our website at hartfordmedicalsociety.org. We are planning to have our annual meeting on September 13th. And we are also planning a gala event in the spring. We had so much fun with Dr. Ezekiel Emanuel. Let's do something else. And we're thinking it's going to be an awards ceremony. So we have some special surprises for that for spring of 2023. I'd also like to thank everyone for watching today and for joining us on our lunchtime webinars. We hope to have some more. And thank you Again, thank you again, Dr. Crombie.
Thank you, Tessa, for arranging it so beautifully. And thanks to all who attended.